Well, good morning, everyone. I'm Mel Wilcox. I direct the Pancreas program here at the DHI in Orlando Health. We're delighted you're here. We have two fantastic and very practical sessions for you this morning, first on pancreatology and secondly on inflammatory bowel disease. We'd like to go a little bit out of order this morning. First, we're going to start with Darwin Conwell, who unfortunately had a important family conflict, couldn't be here, but we're delighted to have him online, so to speak. He is going to be talking on evaluation management of acute pancreatitis. Darwin is currently professor of medicine and directs the Department of Medicine at the University of Kentucky. So Darwin, welcome.
All right, great. Thank you all for allowing me to do this. My brother-in-law retired, and they had a surprise party for him last evening, so I definitely had to attend that. So I really appreciate you guys allowing me to zoom in today. So we're going to talk about the evaluation and management of acute pancreatitis. Most of us all on this call and everyone at the conference has handled many cases with acute pancreatitis, and we're going to cut right to the chase and talk about some practical things about acute pancreatitis. We'll discuss pathogenesis of acute pancreatitis and how that can lead to chronic. We're going to give you a high-level executive summary of acute pancreatitis and discuss some clinical trials and some NIH information. Also, we'll talk about mechanistic underpinnings of pancreatic injury, like why do we do what we do? When we see someone that comes in pancreatitis, why do we give them lactated ringers? What's the underlying pathophysiology of that? And then at the end, we'll talk about some NIH consensus conference workshops and where the research gaps are, where we need to go, and what's happening at the national level. So this is the sentinel acute pancreatitis event hypothesis called the SAFE hypothesis. And we know that when someone gets acute pancreatitis, whether the injury is from alcohol, gallstones, hyperlipidemia, that sets into motion, that sets the stage for potential more injury and more activation of stellate cells, going from a quiescent stellate cells to activated stellate cells that can lead to a lot of fibrosis, inflammation, scarring, and that's what we're trying to avoid. So removal of whatever the offending agent is, whether it's hyperlipidemia, alcohol, gallstones, will help arrest some of this inflammation. Hopefully not, patient will not have recurrent attacks of pancreatitis and will not develop what we call chronic pancreatitis, because we know that we need to minimize or reduce recurrent acute pancreatic injury. If we do not, we will end up with complications. And those complications, as you all know, can be scarring, fibrosis that results in loss of islet cells, which is diabetes, loss of acinar cells resulting in exocrine insufficiency. And of course, these patients can have severe pain, and that's very difficult to treat. So removing the offending agent and minimizing pancreatic injury is very important so we do not have loss of pancreas function. A lot of this is etiology based. So one of the things we need to think about is removing alcohol. Are we counseling our patients to discontinue drinking alcohol? In addition, they need to quit smoking. But this data from Dheeraj Yadav and the Pittsburgh group shows in Allegheny County how alcohol is really a driver of recurrent attacks of pancreatitis. In regard to the SAFE hypothesis, as I mentioned, the initial event, we want to eliminate the offending agent, whether it's alcohol, gallstones, or hyperlipidemia. And this sets in the stage stellate cell activation, going from quiescent to an activated stellate cell. This is the TGF-beta mediated fibrosis, a lot of inflammation. What we want to do is eliminate the offending agent so a person does not get recurrent acute pancreatitis, because we know recurrent acute pancreatitis can lead to loss of pancreas function, and you can result in loss of islet cells, diabetes, loss of acinar cells that can lead to exocrine pancreatic insufficiency, steatorrhea, and also patients can have abdominal pain from inflammation in the nerves. So what we want to do is we need to minimize or reduce recurrent pancreatic injury. Are the slides advancing now?
Yes, sir.
All right, great. Alcohol is a major offending agent. This is the information from the Pittsburgh group, Allegheny County, that shows alcohol versus other etiologies as a driver of recurrent acute pancreatitis. So really working hard at having patients decrease or minimize their alcohol consumption will be very helpful, we believe, in terms of recurrent acute pancreatitis. In addition, we also know that smoking is a major cofactor in the pathogenesis of pancreatic injury. This is the This is the model proposed, the mechanistic model proposed by Dave Whitcomb and colleagues. And what I want to focus on is B, which is the AP-RAP area. So when someone has acute pancreatitis, we talk about the sentinel acute pancreatitis event hypothesis that I went over earlier. We want to minimize and decrease recurrent attacks, because recurrent attacks can lead to scarring and fibrosis, and obviously islet cell, Aschner cell, and duct cell injury that results in what we see in terms of chronic pancreatitis patients that we see in our office and in our clinics. So when it comes to acute pancreatitis, I would recommend that you read this article right here. If you're looking for just a high level, very good review, this is a gut publication from the Dutch group. And as you can see here, most patients, as we know, get mild pancreatitis. Anywhere between 15 to 20% can get severe pancreatitis. And a lot of times that severe pancreatitis is heralded by necrosis. What we see in the center is at the top CT scan is a patient with pancreatitis, and the fluid collection over time, you now can see air pockets in there. This patient's developing pancreatic necrosis. Now later on, you can have walled off necrosis. There's a nice wall around this. And if this patient is symptomatic, then of course, endoscopic intervention is important. You can see the contrast in the stomach, and our advanced endoscopists now are very good at going in and draining these walled off collections. This ultrasound is here because this is to remind us that the most common cause for recurrent acute pancreatitis in terms of idiopathic, if someone's not drinking alcohol, genetic testing is negative, most likely they're going to have microlithiasis. That's up to 75 to 80% of idiopathic pancreatitis is microlithiasis, and this is just sludge in the gallbladder. It's important to note early phase, we give patients lactated ringers. ERCP will be needed for those patients with gallstone pancreatitis. Prophylactic antibiotics or probiotics are not to be used. We now know we can start feeding patients. We don't really need to wait till the pain goes away. We can start them on a low residue diet and start, and that actually will help in terms of getting them out of the hospital. Patients that have delayed recovery, those that may be moving toward necrosis or more severe pancreatitis may need a nasoenteric tube, and that can be a nasogastric tube or a nasojejunal tube. It really does not matter, despite some of the physiology that we know about stimulating the pancreas. If you infuse the nutrition lower down, you decrease the stimulation of CCK receptors in the proximal duodenum. That's felt to decrease pancreatic stimulation, but it does not appear to be a factor when you're feeding patients enterically. Cholecystectomy, of course, should be done in those patients during the initial hospitalization if you can, but this has to be done in consultation with your surgeon. Inflammation, they don't want to deal with a lot of inflammation, that the tissue planes are not going to be easily recognized. These, of course, are done laparoscopically now. So consultation with your surgeon is important, but you definitely want to get it done before the first 4 to 8 weeks of discharge, because the patients will have recurrent attacks. If you have necrosis, as I've mentioned, endoscopic therapy is the preferred methodology and a step-up approach. It's been popularized and published in the New England Journal of Medicine. I've mentioned microlithiasis in terms of that's the most common cause for idiopathic. So thinking about someone that comes back that's not drinking, genetic testing is negative, you don't have a clear cause, and look at those index LFTs, if they were bumped, the person probably has microlithiasis. Get an ultrasound and you may see the biliary sludge. You're not going to see it when they get admitted to the hospital with acute pancreatitis because they've already passed the sludge most likely, and that's what's caused the inciting event. One of the most important things to think about in terms of aftercare is what can happen with this patient down the road. And up to 23 to 25% of patients can get endocrine dysfunction, can get diabetes or prediabetes after a bout of pancreatitis. Also, a subset of patients will go on to develop exocrine pancreatic insufficiency. And these patients do not have to have necrosis. I want to repeat that. They do not have to have necrosis. It can be interstitial disease. And for some reason, and we're studying this, something's going wrong in terms of the immune system. Something's happening with crosstalk between islet cells, Aschner cells. We don't know yet, but patients can develop endocrine and exocrine insufficiency after acute pancreatitis. So follow-up in this aftercare is very, very important for these patients. So why do we do what we do? Well, this is a study that we published with lactated ringers, and it's a randomized trial that showed we compared lactated ringers to normal saline. We found that when you look at goal-directed therapy versus standard therapy, there was no difference. We looked at lactated ringers versus normal saline. You get a lower inflammation, a lower CRP level. We also showed that SIRS is dampened if you have lactated ringers. So systemic inflammation in the biomarker that shows there's a decrease in inflammation. So lactated ringers appears to be helpful. Well, why did we do this? Well, Fred Gorelick, his lab, years earlier, before they published this, had informed us that lactate reduces liver and pancreatic injury in a toll-like receptor, this inflammasome response. So when you look at lactate, what it does, it impacts this GPR81 receptor. The end result is that it does block this NLRP called the inflammasome. The end result, by blocking this, you end up with less cytokines released, so you have less inflammation. That's felt to be the mechanism of how lactate works. I think it's important to update you now on the literature. Aggressive or moderate fluid resuscitation, acute pancreatitis. This, of course, is the waterfall trial. And what did they show? Aggressive therapy can lead to moderate or more severe pancreatitis. It also can result in fluid overload. And I would just say be careful with aggressive fluid resuscitation. I would just say we know patients need to be treated with a lot of fluid, but you got to keep track of these patients very carefully and don't just flood them. So I think just being careful, being a good internist, making sure that you're at the bedside monitoring these patients and adjusting this adjusting your fluid is the way to go. But just blindly just flooding them is not going to work. The waterfall will result in a lot of pulmonary edema, ARDS, and they'll be in the ICU on the ventilator. So let's wrap up this section. This is a paper that we wrote several years ago when I was at Brigham, but these slides will be available for you. This is a great a review in regard to when someone has pancreatitis, assess severity, what's the initial resuscitation, is fluid, try to determine the etiology. And what I'm highlighting over here, lactated ringers should be given, cholecystectomy done for those patients with gallstone pancreatitis. Enteric feeding will be needed for those that have refractory and persistent SIRS, ERCP, of course, for those with gallstone pancreatitis. This CT shows necrosis in a patient that's not doing well. This shows an enteral feeding tube that's placed further down to help with nutrition while a patient is recovering from their pancreatitis. This was a NIH consensus study looking at accelerating the drug delivery pipeline and looking at acute pancreatitis. These are done at Pancreas Fest, the Wednesday before Pancreas Fest starts. I would really encourage those who are interested in pancreatic disease, wanting to know what the latest research is and where the research gaps are and where the field is heading, to attend to that meeting at Pancreas Fest. It's always been in Pittsburgh. This year it's moving to the University of Cincinnati. It's always done in July of the year. Take home points. Patient selection is important. The majority of people have interstitial disease. So when you're looking at drug therapy or trying to intervene, you got to try to identify and predict those that are going to have severe acute pancreatitis. And it's difficult. How do we predict that in the ER within the first 24 hours? And there's some biomarkers being developed and other things that are coming out of the Ohio State group, George Papachristou, that shows there may be some biomarkers that will help us identify early acute pancreatitis. Patient-reported outcomes are important. A lot of clinical trials are needed in this area, as you all know. I want to show you one study from the NIH called the DREAM study. I've told you that routine screening for diabetes. I told you that patients will develop a diabetes after acute pancreatitis. This report shows 23% in this meta-analysis, so 20 to 25% will develop diabetes, but routine screening for diabetes is not recommended. It's not been suggested by any of our societies. And the underlying cause of this is unknown, but it does afford us the opportunity to study this in more detail. So the DREAM study was formed after this consortium called the Type 1 Diabetes and Acute Pancreatitis Consortium was developed, and the primary objective is to develop a prospective longitudinal observational clinical study to investigate the incidence, etiology, and pathophysiology of diabetes after acute pancreatitis. And the nice thing about this is this study, this has been published in Pancreas. You can look this up. These are the centers that are participating and were selected to be in this consortium. Patients enrolled 90 days after enrollment will undergo a very extensive longitudinal metabolic testing, looking at, they're looking at OGTT, MMTT, and FSIGTT, along with MRI scans, and a biorepository is being developed and is already organized. We are actively enrolling patients into this study right now. I did look at clinicaltrials.gov to kind of update everyone here on what's going on in the literature and what's happening right now out there for you to think about, to know what's coming down the pike. There's a very exciting trial looking at pirfenidone and acute pancreatitis. Also, the Hungarian group is looking at alcohol and smoking cessation, which is very important, as we talked about earlier, in regard to trying to eliminate recurrent acute pancreatitis. Pain's a big problem. There's an opioid receptor antagonist being looked at by the Denmark group. And of course, I told you about the DREAM study, trying to figure out the underlying mechanistic underpinnings and pathophysiology of diabetes related to acute pancreatitis and its mechanisms. There's a nice R01 from the Ohio State group, George Papachristou leads, called the MOSAIC study, Immune Signatures and Clinical Outcomes in Acute Pancreatitis. Of course, we are aware that infliximab is being studied in the UK. The SHARP study looks at pancreas divisum and its role in acute recurrent pancreatitis. There's a study looking at rectal indomethacin and oral tacrolimus from the Hopkins group. There's a interventional study ongoing right now. Also, we know about CARPO, which is the Oxora in acute pancreatitis. And there's also investigators looking at regular versus clear liquid diet for mild to moderate acute pancreatitis. So clinicaltrials.gov is good to go in there and just type in acute pancreatitis and see what's going on throughout the world. So just to finish it up, in terms of our approach further on, this is the second article that Beach and Wu and I wrote to try to summarize and kind of put things together for pancreatitis. So after someone has acute pancreatitis, what's important to do is to look for long-term complications, such as the development of exocrine pancreatic insufficiency, the development of diabetes, the development of walled-off necrosis for those that have severe pancreatitis. This X-ray shows acute pancreatitis, and then to the right of that, now we're starting to develop necrosis. And when they get walled-off necrosis and it's symptomatic, then of course you have to debride this, and this just shows a basket removing some of the debris from the necrotic collection. The bottom left is a patient with a fluid collection in their left lung, and this patient had a pancreatic pleural fistula. And Dr. Thompson, when I was at the Brigham, stented this, and the patient got a phenomenal result. So looking for diabetes, thinking about EPI, getting the gallbladder out in a timely fashion, and monitoring for walled-off necrosis. And some of these rare complications, this is a pancreatic pleural fistula, can develop. So to wrap up, we've talked about the SAFE hypothesis, that sentinel event, and the need to remove the stimulus so you don't get a recurrent acute pancreatitis situation and result in chronic pancreatitis and its sequela. Research gaps. We've got to figure out how we can identify early acute pancreatitis if we're going to intervene during the hospitalization. I've told you about the mechanistic underpinnings and why we do what we do, why are we giving lactated ringers. Gave you a research update from clinical trials, and PubMed talked about the waterfall trial and where we are right now at the NIH level in terms of consortiums looking at acute pancreatitis. So thank you very much, and I appreciate your time. I do want to thank you, Mel, and everyone for allowing me to do this online. I was looking forward to getting to Orlando. The weather here is getting kind of cold, so it would have been nice to hang out with you all for a few days. But thank you very much for allowing me to do this.
Thank you, Darwin. Enjoy your family event. So next we have Dr. Veggie, recent president of the International Pancreas Association, who directs the pancreas program at Mayo Clinic in Rochester, talking about a very difficult topic, I think, for all of us, namely management options for pain associated with chronic pancreatitis. Santhi, welcome.
Thank you, Mel. Good morning, everybody. Wonderful to be here yet again. Thanks to Mel, Shyam, Rob, Jin, and other colleagues. Management options for pain associated with chronic pancreatitis. These are my disclosures, some NIDDK, NCI, and Department of Defense federal grants. But most important is the PROCEED consortium. We have here Biraj, Darwin, we are all part of that consortium, which is in year 8. And this is going to give extremely important information in this disease based on a large number of patients. I do write chapters in UpToDate, but the most important disclosure I want to make is I consider myself as a practicing clinician in the clinic because that's what I've done full-time for many decades, like most of you. I'm going to not present a lot of data and numbers to you, but I'm going to be mostly showing you statements which I think in my practice what I do. So some of the things that I'm going to show you are in this recent review article that I and Suresh published last year. So why do we intervene in chronic pancreatitis? Mainly 3 issues. It's the pain, exocrine, and endocrine dysfunction. The main problem is, of course, pain. Pain, pain, and pain. About 10 to 28% of the patients with CP may not have pain, so-called, quote, painless pancreatitis, painless chronic pancreatitis, unquote. But usually these are the people, as you know, chronic upper abdominal pain. Attacks going to the ER are getting admitted with documented acute pancreatitis superimposed or attacks without acute pancreatitis documented. More than $500 million annually spent on this. Low quality of life, psychological stress, high resource utilization, and disability. The classic CT scan, as you know here, all the 3 features are there, which you see often in your practice. Calcifications. I'll just see if I can show this. Anyway, I think
Screen, yeah. Yeah, use the mouse.
does this, yeah. So, ductal calcification, dilated duct, and atrophy of the gland. This is the classic CT. So, in the routine clinical practice, when we say classic or usual chronic pancreatitis, we have 3 types. One is the typical alcohol and smoking. You know it too well. The second one is late onset, previously called senile. We don't use that word anymore, politically inappropriate. So late onset, most of these people are idiopathic, and quite often they are painless. And the other one is idiopathic early onset, and here most often you may find genetic mutations of the 4 or 5 or 6 mutations that you test. The others are all separate, AIP, obstructive, PRSS1 related, etc. So these are the 2 studies which showed that in a proportion of patients with CP, there's no pain. The Dutch national study showed about 28% are without pain, but the the meta-analysis that was done based on large number of studies showed approximately 1 in 10 patients of CP may not have pain. So our discussion today may not be pertaining to those people. So why do you get pain in chronic pancreatitis? For years we said, and we based our decisions on ductal hypertension, pancreatic duct more than 5 or 6 millimeters, parenchymal hypertension, that means pressure increase in the parenchyma due to stones and other fibrotic tissue, and then pancreatic neuritis, the nerves within the pancreas getting hypertrophied as well as hyperplasia, and the complications like cancers, bile duct stenosis, pseudocyst, duodenal obstruction, etc. But for the last 10-15 years, our experts in pain started saying that the pain in chronic pancreatitis is due to pancreatic neuropathy, which starts in the pancreas, hyperplasia, hypertrophy. Then it goes to the afferent nerves going to the spinal cord, then the spinothalamic tracts going to the brain, then the sensory cortex, and then the descending inhibitory pathways. These things all change. When these change, it is called central sensitization, neuroplasticity, and that results in visceral hypersensitivity. You know at the bedside, when you start examining the patient, before your hand touches the patient, he jumps up and hits the roof. So this figure is very important. Actually published in 2011 when I was speaking in DDW for the pain in chronic pancreatitis about 12 years ago. But it is still the most important thing. As you can see, most of the times we think that the pain is coming here from the pancreas and we do all interventions, but Quite often, very early on in the disease, once the disease is diagnosed, it just moves outside the pancreas to all the areas I have mentioned. So this is an important concept. We always think about acting on the pancreas, and then you see why these people, after either they don't respond or they respond and come back to you after about 1 year or 2 years back with the pain, and then we don't know what to do. So when you have a patient with chronic pancreatitis, you have some tools to assess both at the initial time when they have pain and after you give some intervention to see how your intervention responds. If you go to the left side here, the clinical research tools are visual analog score for your pain, quantitative sensory testing, which hopefully will come soon into clinic, functional MRI of the brain, where you see the sensory cortex lighting up much more than normal because of the abnormal sensitization, cold pressor endurance, reflex thresholds diminishing, quality of life questionnaires for the outcomes. Different types of questionnaires are there, and now patient reported outcomes, because all the time we assess the outcomes, but it is important for the patient. But when you move to the clinic, like most of the people treat the patient with chronic pancreatitis, you don't have these things, or you don't have to use. These are clinical research things. We still do the basic clinical thing: history, physical examination, and then use your gut feeling or horse sense, which you have developed over 10 years or 20 years or 30 years, whatever it is. Because that's the way you are in the clinic and the patient is in front of you across the table. So how do we intervene for these people? We have pills, we have scope, we have knife, and we have other gadgets. But there is a concept called homo faber. This is a Latin word, which means man the maker. Once again, it has to be human, not man, because, if you say man, there is no woman here. But the concept here is humans are able to control their fate and the environment as a result of use of the tools. This is there from millennia that's being done. So like, for example, if you have the hammer as your only tool, and if you're walking in a corridor, every problem you see as a nail because you want to use the hammer. So here, coming back to that concept here, we have the medical tools: NSAIDs, tramadol, narcotics. We have the endoscopic tools: stent, stricture dilatation, electrohydraulic lithotripsy, laser lithotripsy, all with the scope. We have extracorporeal shockwave lithotripsy that we used to use for a long time for the kidney. We have surgery. It's either a drainage of the dilated duct or resection of abnormal areas. We have total pancreatectomy with islet cell autotransplantation, and we have miscellaneous procedures like celiac block, acupuncture, spinal cord stimulation, etc. Once again, as you see, we think that these are all the things that we have to use for chronic pancreatitis because we are focusing on the pancreas. But what we need to do now and change our thinking a little bit right from the beginning when a diagnosis is made with calcification, etc., they're already started having sensitization, so something more needs to be done. And that's where the pain rehabilitation, where they give neuromodulators, cognitive behavioral therapy, acupuncture, and so many other things. So if you look at the overall treatment plan in this slide, which is very busy, sorry for that, I would think that we have to use tramadol and NSAIDs more often because there is a basic science rationale. The PGE2 levels, NSAIDs block them, and by blocking that in the pancreas, the inflammation comes down. The pancreatic enzymes meta-analysis showed that they are of no relief, no use for pain relief. However, if somebody has maldigestion, bloating, borborygmi, distension, discomfort, you can try them. But my advice to you is it's not necessary to go beyond 48,000 units of lipase at all. Beyond that, there is no scientific proof that actually it helps, and it only helps whom? The drug companies, not the patient, not you. Antioxidants are, I think, important because there is no downside. There are extra pancreatic benefits, cardiovascular, etc., etc. Instead of going for some set pill or something for antioxidants, just ask your patients to take colored vegetables both for lunch and dinner. Ask them to take a multivitamin with minerals and vitamin A, C, E, and the minerals being selenium and molybdenum. You have them in the center of silver is one example. And then berries, both in the morning and evening if they have. This is the best antioxidant treatment. No downside, and there is a randomized controlled trial evidence that the pain in chronic pancreatitis may be benefited. The opioids, which we all use like candy, we have no control on that, have many problems besides the narcotic bowel, opioid-induced hyperalgesia, which actually aggravates all the sensitization process in the afferent nerve, spinothalamic tract, sensory cortex, etc., etc. Coming to the structural interventions, of course, the most frequent intervention, as you know, is endoscopic approach, stricture dilatation, plastic stent, 10 French placement, every 3-4 months exchange, at least do it for 1 year. If you have stones less than 5 millimeters, you can break them with electrohydraulic lithotripsy or the laser lithotripsy, and the new laser lithotripsies have come. If the stone is bigger than 5 millimeters, you have to use extracorporeal shockwave lithotripsy if you have one, and then fragmentation, and then remove these things. This surgical treatment, which is usually drainage of the dilated pancreatic duct with removal of the stones, etc. The commonest is called FREY, Fry's procedure. Although the level 1 evidence, that is 3 randomized controlled trials showing that surgery is more durable relief and all, you know it very well. If you offer to the patient would first like to go for endoscopic treatment. Even your surgeons will say, let's try the endoscopic treatment. So eventually most of the people will get first endoscopic treatment. So you have to choose your endoscopist who is very, very experienced. The TPIAT is a research setting, and I'll tell you very soon why. Celiac block, acupuncture, spinal cord stimulation, very little evidence. Although celiac block is used extremely commonly, there is no real level 1 evidence that it helps. And once again, we come to the pain management, which is going to be a crucial part of pain treatment in chronic pancreatitis. And hopefully, it is going to be used in almost all the patients going forward with the knowledge that I'm now telling you. So, the neuromodulators, which is one of the most important things that the pain management or pain rehabilitation folks use. Once again, you are familiar with this for various other neuropathic processes of the GI tract and elsewhere too. Tricyclics, you know very well, and SNRIs, serotonin norepinephrine reuptake inhibitors. You know Cymbalta, duloxetine, and effects of venlafaxine. And gabapentinoids, you are all familiar. Not only gabapentin, but pregabalin, for which we have level 1 evidence in chronic pancreatitis. One thing I want to tell you here, it's very easy for all of us to say in these slides, pain management, pain rehabilitation actually, but the pain rehabilitation good centers are very, very few, far and in between, number 1. Number 2, their appointments go for months, and these people by that time have narcotic problems and other things. Number 3, the insurance doesn't pay most of the time. Number 4, they have to stay a minimum, usually 3-week program. And if the patient comes to, say, Rochester from, say, Louisiana, it costs a lot of the things. So it's most of the times, if I order this for 10 patients, I'm lucky if I can get 1 completed. So this is the most recent randomized controlled trial comparing surgery with endoscopic treatment for painful chronic pancreatitis. Prior to this, there were 2 more too, and this shows that up to 18 months, there is a more durable relief if you operate on the patient. Of course, there are a lot of methodological questions raised by our endoscopy colleagues and back and forth correspondence, letters, etc. in NEJM everywhere, but I just wanted to show you what is there. And the surgeries, when we say surgery, what do you mean? One is if you have a mass-like thing in the head of the pancreas, you go for Whipple, whether it's classical Whipple or pylorus preserving Whipple. But most often what is done is called duodenum preserving pancreatic head resection, DPPHR. The FREY, Fry's procedure, Dr. Fry from West Coast, whom all of us adored for many, many decades, he described this, where you core out all the fibrotic tissue and the stone material in the head of the pancreas, then put a limb of jejunum to the dilated duct in the body and tail and do a Pustow procedure. Then, of course, you have TPIAT, which you all know very well. So this is actually the pseudocyst here with a cyst jejunostomy limb, but this is a Pustow that you all know for a long time, longitudinal pancreatico-jejunostomy, once again with a limb here. And the Fry procedure, which is what I would like you to know clearly, is core out all this area, stones, fibrotic material, sent to the pathologist if there is a small cancer there. Only 4% of chronic pancreatitis or less will get pancreatic cancer. So there is no screening for pancreatic cancer. It's a very rare event. And then you do the Q-stool here. Total pancreatectomy with islet cell autotransplantation being advocated vigorously by centers who do the procedure, open access, and even for minimal change chronic pancreatitis, it's being done, which I think is extremely inappropriate in my opinion. And the earlier referral is requested by the centers because you get much higher yield. However, it should be done only as a study protocol. There is no randomized control trial comparing this with any other therapy, or for that matter with total pancreatectomy without islet cell transplantation, because you have now so many effective ways of treating such pancreaticogenous diabetes with closed loop systems, artificial pancreas, etc. The insulin independence at best is 20-30% at the end of 3 or 5 years. And about 30% of the people still require narcotics, and they keep coming and seeing all of us. And after doing total pancreatectomy, if they're still having the pain, and you did it for pain, I think it's not good. And that's because of the sensitization, they still have pain. So here, a good surgeon is one. It takes 3 years to learn how to cut, but it takes 30 years to learn when not to cut. So the surgeon should really know who are the patients where by doing operation they'll get benefited, and who are the people where we all should stay away from them. So lastly, just to show you some examples, here you have this dense calcification in the parenchyma as well as in the duct, and then dilated duct. Either you can do ESWL 2-3 sessions, and then ERCP and stent placements 2-3 sessions, maybe about 3 months, few procedures. Or if the patient is very young, I usually refer this patient for Fry procedure one time, and then you are done. Whereas if you come to the second situation, this is ideally suited for endoscopic treatment. One stone, it is more than 5 millimeters, ESWL, break it, and then do the endotherapy with stent for some time. Or if you have very good new laser therapies and all, the endoscopists on the table without as well can do that too. And the C is also a good case for endoscopic therapy, localized stricture chronic pancreatitis, dilate, 10 French stent, every 3 months exchange, keep it for 1 year. And the last one is a mass in the head of the pancreas, no dilated duct. This is the situation where you have to do a Whipple surgery. And even if it turns out to be no cancer, which you know 80-90%, you are doing a Whipple for a benign disease, and it is acceptable. And there are people with huge series, 100 plus, etc. So lastly, in the clinic, you will know that a pure structural intervention, endoscopic or surgical, won't work if the pain is greater than 3 to 5 years from the time of diagnosis, because the sensitization has started. And if it is a 24/7 pain, the patient tells you all the time the patient has pain. And if they are on narcotics for more than 6 months, because visceral hyperalgesia, opioid-induced hyperalgesia has set in, and if they are having depression and anxiety, if they're still smoking and drinking, and if they have visceral hypersensitivity on your examination. So it is now an interrelated multidisciplinary treatment that is probably required for most of the patients if we want to give them a durable relief and bring them back into the society as useful human beings. Structural interventions we have talked on the left, pain rehabilitation, things we have talked on the right, and somewhere in between you also have to have psychologists, psychiatrists doing their anxiety, depression treatment. So this is the last slide. So you have on the left academic physicians doing clinical research, practicing the science of medicine, very important. That's how we get all the knowledge to be taken to the bedside. And on the right, you have doctors in the clinic taking care of the patients, where you are directly confronted with the patient. And here you have to practice the art of medicine with the help of what you got from your clinical research scientists. And so I think I will stop here. The final point being that please be aware that there is a neuropathic process that is there in most of these patients, and that has to be treated. Treating only what you see in the pancreas by the tools you have may not cut it. Thank you.
Thank you, Santhi. Excellent overview. Next, we have delighted to have Dheeraj Yadav, who's professor of medicine at the University of Pittsburgh. Many of you, I'm sure, have read some of his works as directing the NAPS2 cohort. Has published a lot on, of course, chronic pancreatitis. But today he's going to talk on, I think, a very important area. That is molecular genetic markers in pancreatitis. Are they useful, and when, how to obtain? Welcome, Dheeraj.
Good morning, and thank you, Mel, Shyam, and Rob, for the kind invitation. So I've been tasked to discuss with you about molecular genetic testing in pancreatitis. Are they useful, and when and how to obtain? These are my disclosures, which are not related to the presentation. But I want to disclose that I'm not a geneticist and I'm not a basic scientist, but I'm a clinician who sees lots of patients with pancreatic disease. And what I'm going to be doing this morning is, in the next 15 minutes, walk you through etiologic workup of pancreatitis the way that we do in our practice. And that will lead me to genetic testing in pancreatitis in terms of why should you test, who should you test, and how this can be helpful in managing your patients. And then lastly, I'll touch upon something that we have incorporated into our clinical practice more recently, serum PET testing, which you will probably hear more in the near future. So I'll start with etiologies of pancreatitis, and Dr. Conwell actually very nicely reviewed with you workup for patients with AP. What this slide shows is organization of etiologies based on different forms of pancreatitis, first attack of AP, recurrent AP, and chronic pancreatitis. And there are some things that I want to highlight here. The first is that in patients who have RAP, the etiologies are usually similar to the first attack and depend upon what sort of a workup that the patient has had until the time that you are evaluating the patient. Then also we need to think about complications from prior attack of AP. For example, the patient could have developed a stricture in the pancreas duct that could be fueling their attacks of AP. The second thing I want to highlight here is as you go from AP to RAP and CP, the proportion of patients who have alcohol, genetic, and idiopathic etiologies increase. And the reason for that is many of the modifiable factors, for example, gallstones, triglycerides, medications, and so on, have already been addressed. And the last point that I would like to make here is it all depends upon who's your patient. That will determine what the most likely etiology of the pancreatitis would be. What is the age of the patient, the sex of the patient, the race of the patient, and so on. Now, when we think about workup for first attack of AP, in context of the discussion today, a good clinical history can be very helpful. For example, asking the patient in terms of do they have a family history of pancreatitis, pancreatic cancer, cystic fibrosis, or celiac disease can be helpful to give you a clue to underlying genetic etiology. Asking the patient himself or herself in terms of whether they have recurrent sinus infections, whether they have recurrent pulmonary infections, whether there is history of male infertility, could give you an idea with regard to underlying cystic fibrosis as the cause of patient's pancreatitis. Now, these are the guidelines from the International Association of Pancreatology published a few years ago. Liver function tests are helpful, and ultrasound is helpful to get an idea with regard to gallstone etiology. Serum triglyceride should ideally be checked as early as possible after admission, because if you delay it even 24 to 48 hours, you can completely miss the diagnosis. I put CT scan here not as a recommendation, but in the US, 70 to 80% of patients get a CT scan anyway. But in our practice, if we do not find an etiology until then, we usually send a celiac panel in all patients because a small fraction of patients can have celiac disease as an underlying cause. We do serum IgG4 testing in select patients, and I want to caution here, the reason for that is that in a patient with acute pancreatitis, diffuse enlargement of the pancreas could just be because of pancreatic inflammation. So serum IgG4 can be non-specifically elevated in many patients. So unless the patient has the typical presentation of autoimmune pancreatitis, we do not do serum IgG4 testing. And I'll cover PET testing in a few minutes. When a patient comes with second attack or subsequent attack of acute pancreatitis, again, a good history is helpful. And depending upon what lab workup has been done, you may want to do that. But if the workup is negative until then there is a role of an endoscopic ultrasound. A secretin stimulated MRCP is preferable over a standard MRCP. And then if the etiology is not sure, then you may want to think about genetic testing. What an endoscopic ultrasound can do is it can help to detect occult stones or sludge in the gallbladder that has not been previously picked up by an ultrasound or even a CT scan. It can also show you presence of a small ampullary, periampullary, or a pancreatic head lesion that has not been diagnosed. Again, think about an older patient coming with the first or the second attack of acute pancreatitis, and the CT is negative. In that patient, there could be a pancreatic cancer. The EUS can also give you an idea with regard to chronic pancreatitis, because chronic pancreatitis can present as acute or recurrent acute pancreatitis as initial manifestation. The caveat here to remember is that acute pancreatitis can also cause parenchymal changes because of inflammation, and you may want to wait for a few weeks before this is done. MRCP can be helpful to uncover ductal abnormalities that have not been detected. For example, I've mentioned to you about a pancreatic duct stricture. It can also show you abnormalities like seen here, pancreas divisum, where the main pancreatic duct, rather than going down to the ampulla, it is crossing the common bile duct for the classic appearance of divisum. It can show you presence of a main duct IPMN. In these patients, because of presence of mucin in the main pancreatic duct, there is obstruction of the duct causing pancreatitis. Or it can also show you some uncommon abnormalities that are shown here, like pancreatico-biliary junction abnormality, annular pancreas, or cystic dilatation at the level of the minor or the major papilla. So if the etiology is unclear, the way we approach is if you have a patient with RAP or CP, we consider genetic testing in a patient who has idiopathic disease. Dr. Vege already mentioned to you about the early onset and late onset. There's an arbitrary cutoff of 35 years of age to call them less than 35 or more than 35. But we also consider genetic testing in select patients who have a history of alcohol consumption, but you're just not sure whether alcohol actually explains their disease or not. We usually do not do genetic testing in patients with first attack of AP unless there are certain specific issues. For example, if you have a 20-year-old male, 25-year-old male comes in with first attack of idiopathic pancreatitis, you may want to think about an underlying genetic etiology, especially if there is some sort of a family history also there. So if you think about genetic mutation, this is the list of genetic mutations or genes that are pancreatitis susceptibility genes. The list is going to increase over time as we uncover more genetic susceptibility factors. I've highlighted the 4 most common ones: PRSS1, SPINK1, CFTR, and CTRC. The way that these can be organized is depend upon inheritance. For example, PRSS1 is an autosomal dominant disorder, CFTR is autosomal recessive, Claudin1 is X-linked, and then others have polygenic inheritance. They can also be classified in terms of underlying pathogenic mechanism. For example, whether they are affecting the trypsin pathway, so there is either increased autoactivation of trypsin, or the activated trypsin is not shut down, or say, for example, CFTR, where it affects the secretion of fluid in the pancreas duct. So because of that, there is clogging of enzymes, and their enzymes are not being flushed, and there is autoactivation, and so on. But I do want to spend a couple of minutes about CFTR and pancreatitis because this is important and complex. If you think about CFTR disease, there are 3 important clinical manifestations. The first is classic cystic fibrosis disease. These are patients who have 2 severe mutations on the 2 alleles. Because of that, there is virtual destruction of the exocrine pancreas, usually in vitro or shortly thereafter. These patients are pancreas insufficient and need lifelong enzyme supplementation. These patients do not have clinical pancreatitis. If you look at their CT scan, you'll see the whole pancreas is fatty replaced. 15% of patients who have cystic fibrosis disease are so-called pancreas sufficient. That means the pancreas looks normal on a CT scan because a certain amount of CF function is retained. But these are the patients who have very high risk of clinical pancreatitis, about 25 to 50-fold greater than the background population. And then third is a group of patients who are called atypical CF. These were the ones that were included in the initial reports in late 1990s for the Association of Idiopathic Chronic Pancreatitis and CFTR. These are patients who are something called compound heterozygotes. That means they have 1 severe mutation on 1 allele and mild to variable mutation in other allele. So they have reasonable amount of pancreas function, but they are at increased risk for clinical pancreatitis. It also depends upon what type of mutation somebody has. There are over 1,500 CFTR mutations. Of those, only a handful are those that are pathogenic for CF disease. A large number are benign, so when you send genetic testing, often you'll get a report, patient has 2 CFTR mutations, but they are both benign mutations. What to make out of this, we are not completely sure about. The third thing is, what is the type of defect? CFTR disease is because of chloride channel abnormality. But there are some subsets of CF mutations that are bicarbonate specific. Pancreas is one organ where bicarbonate transport is important for fluid secretion. Reproductive organs are others. So some patients with bicarbonate specific mutations could have only pancreas specific disease. They may not have any lung disease. So that's something important to remember. This is probably the most important slide of my presentation because this provides a conceptual framework of understanding the role of environmental and genetic factors in pancreatitis. So each one of us in this room has an inherent risk for pancreatitis. But pancreatitis is an uncommon disorder. So the majority of us will never manifest pancreatitis because we'll be long dead by that time. What happens is, in the presence of risk factors, the clinical presentation of pancreatitis is accelerated. The most common scenario is a patient who drinks heavily, usually in the combination of smoking. 20, 25 years of drinking is needed. That's why they don't present at 20 years of age. They present between 40 to 60 years of age for the exposure to accumulate over time. Then you can have patients who have late onset idiopathic disease. Dr. Vege mentioned these are patients who are 60s and 70s, may not have a lot of alcohol consumption, may be smokers, but they may have some other risk factors, maybe genetic or others that we don't know. Now, like any other genetic disorder, the severity of the mutation determines the age of onset of disease. So for example, PRSS1 is a very severe mutation, and that's why the clinical presentation in these patients is in the first or the second decade of life most commonly. Then you have patients who have SWINK1 or CFTR mutations. They usually present in the second or the third decade. And then you have patients who have so-called early onset idiopathic, where we don't know what the underlying genetic susceptibility is in second to the fourth decade of life. The point that I'm trying to make here is it depends upon who your patient is, what is their age, what is their presentation, for you to determine how much influence genetic factors would have in that patient. Now, if you do genetic testing in a patient with idiopathic pancreatitis, how often will this be positive? So these are data from the NAPS2 study, where we organize patients into early onset idiopathic pancreatitis, late onset, and then varying amount of alcohol consumption. PRSS1 positive patients, which are about 5% of the study population, were excluded. But in these patients, if you look at the second column, among patients with early onset disease, almost half of them had either a SPINK1 mutation, CFTR mutation, CTRC, or a combination, which was twice as compared to the other group of patients. These are data from an independent cohort from Johns Hopkins, where over a 7-year period, patients who were seen for evaluation of pancreatitis, and among those who had RAP and CP, that was idiopathic, commercial testing was done in a variety of labs like LabCorp, Ambry Genetics, Aerial Precision Medicine, and so on. And they also found that 50 to 65% of patients would have one or more genetic mutations in this specific setting. Now, the next question which comes up is, I know who to test, how to test, but how will it help the patient? And perhaps the most important thing that's going to help a patient is, you have a patient in front of you who has pancreatitis, you don't know what's causing it. What's the most common thing that happens in many of these patients? They go to the ER or they go to a doctor's office and they are said, you drink alcohol and you are just not telling me about it. Which may be positive, which may be true in many cases, but not in all cases. So understanding what is the underlying cause of pancreatitis is a very big deal for you as a physician and healthcare provider, but more importantly for the patient and family members. So that's perhaps the most important reason why this could be helpful. The second is, at this time, we do not have mechanism-based therapies for patients with pancreatitis. What I mean by that is, if you have a genetic mutation, you do this treatment and we'll help you. But there are emerging data like CFTR modulators that I've shown here in a series of patients who had mainly pulmonary disease and an indication for CFTR modulator. There was a substantial reduction in the number of episodes of pancreatitis after starting treatment. So hopefully in the future, mechanism-based therapies may be helpful in these patients. And lastly, I want to touch upon serum PEth testing. PEth stands for phosphatidylethanol. This is a metabolite of alcohol that resides in the red blood cell wall. In contrast to serum alcohol that is positive maybe only for 24 to 48 hours after alcohol consumption, or urine metabolite that are positive for up to 7 days, serum PEth can be positive for almost a month after consumption of alcohol. So think about a situation where you have a patient who comes in with an attack of acute or recurrent acute pancreatitis, and you just don't know whether alcohol was the cause of pancreatitis in that patient, alcohol history is reliable or not, and you can do this testing. The level of serum PEth correlates with the amount of alcohol consumption. It is not impacted by age, sex, medications, and there are rare false positives. And now it is used very routinely in a lot of medical and legal settings. So in the last 3 to 4 years, we have incorporated PEth testing in select patients, and we have found that when you're suspecting alcohol etiology because of the factors that I told you, it can help you to uncover the etiology in about a third of patients. And there is actually a paper that we and Greg Cote put together and is under review right now, where the yield was about 1/3. And the second is, if you have a patient who has known alcoholic pancreatitis, patient says, I've stopped drinking, you have a patient with obstructed pancreatic duct and you're thinking whether I should do endotherapy or not. In this patient, a PEth level can tell you whether there is occult alcohol consumption, because that could affect your plan for management. So to summarize, the extent of workup for patients with pancreatitis depends upon a lot of factors, the form of pancreatitis, demographic factors, and so on. Identifying an etiology provides the best opportunity for preventing future attacks and slow disease progression. Genetic testing can be helpful in a subset of patients to help to establish the etiology, and hopefully over time, maybe mechanism-based therapies. And PEth testing can be helpful to identify occult alcohol consumption in patients with pancreatitis to establish etiology and to make treatment decisions. Thank you.
Thank you, Dheeraj. Our last talk this morning is by Dr. Anne Marie Lennon. She's a professor of medicine and directs the GI program at Johns Hopkins, but will be leaving there and being the chief of medicine at the University of Pittsburgh, so we congratulate her on that. Anne Marie is a world expert on genetics in pancreatic cysts and their approach, so today she's going to share her knowledge with us on a practical approach to pancreatic cysts for the general gastroenterologist. Anne Marie, thank you for coming. I know you're busy.
Not at all. Thank you very much. It's a real pleasure to be here. Yeah. Perfect. So can I have a show of hands? How many people here have a patient with a pancreatic cyst? Do we have one or two? Oh my goodness, almost everybody. Well, so I was being told very clearly this needs to be a practical approach, which is exactly what we're going to talk about today. So 2/3 of this talk is we're going to talk through a case and work through it, and then I'm going to talk a little bit about the future, some of the challenges we have in the future. And I have no disclosures that are relevant to this presentation. So we have got through this wonderful meeting, and we're back in clinic, and it's Wednesday morning, and this patient comes in to see you. And she's a 68-year-old female. She has an incidental finding of a cyst on her CT scan, which was done for lower abdominal pain. She has no history of pancreatitis, jaundice, diabetes, no family history of pancreatic or related cancers. You can see the cyst here. It's a 2.7 centimeter cyst in the head of the pancreas. And on the report, it says it appears to communicate with the main pancreatic duct. You're told that the duct measures 3 millimeters, and your radiologist, we've heard all these great talks about pancreatitis, acute pancreatitis, chronic pancreatitis, and they say, hey, we think this is a pseudocyst. The patient was referred for an endoscopic ultrasound, which was done here. The endoscopic ultrasound, when you get the report, it says the cyst has a thin wall. There is no solid component. They stuck a needle into it, did an EUS-FNA, and they sent it for a couple of different tests. They sent it for a CEA, and the number comes back as 354. They sent it for glucose, and the number comes back as 22. They sent it for cytology, and it says no marked atypia. And they also sent it for molecular markers, and it comes back saying it's a KRAS mutation. So how do we interpret all this, and how do we approach our patient? The first question that we should think about is, should we be doing surveillance at all? And in patients who are not medically fit for surgery, they should not undergo any further evaluation. So I don't think that this has to do with age. You may have people in their 40s and their 50s, some people in their 80s. The first question when you see a patient is, are they fit for surgery? Should you be doing it? And if not, we shouldn't go down this route. But this is a young lady. She is very fit and healthy, so we're going to continue on our odyssey. So pancreatic cysts are unbelievably simple. You have only two questions that you need to answer. First, what type of cyst do you have? And secondly, that will allow you to determine what is the risk of malignant transformation and then what you need to do. So for example, we have some cysts, such as pseudocysts and serous. They have no malignant potential, and those patients don't need any follow-up. On the other side, we have patients with pancreatic cancer. Those clearly have malignant potential and they need to be sent to surgery. And then in the middle, which is the only reason we're really interested in pancreatic cysts, we have two cysts called IPMNs and MCNs. They account for 2 of the 3 precursors to pancreatic cancer. They obviously have malignant potential. The vast majority of those cysts will never turn into cancer and simply need to be followed, but a very small number will, and those small numbers, that's really what we're trying to do, is identify which patients have an IPMN or an MCN, and of those, which very small number have either cancer, pancreatic adenocarcinoma, or high-grade dysplasia and should be referred for surgery. Seems simple. Okay, so let's start off with the question. First question, what type of imaging should we do? The vast majority of imaging for pancreatic cysts is done with MRI. It has no radiation. It is relatively easy to do. It sees the cyst well. It sees the pancreatic duct well. Remember a couple of things. It's not perfect. So you can see here, this is a systematic review and meta-analysis. It's imperfect for telling you what exact type of cyst you have, and it's moderately good for differentiating benign from malignant cyst, but again, not perfect. What else can we use? Well, we have endoscopic ultrasound. It is more invasive than MRI, and therefore we only use it in a smaller number of patients. But it's the most sensitive test that we have to identify a solid component, a lump, or a mural nodule. And if you see that, your patient has an odds ratio. So if your EUS report comes back saying solid component, you have an odds ratio of just over 9 for the presence of high-grade dysplasia or pancreatic cancer. And you can stick a needle in it and sample the cyst. Okay, I said I'd make this easy for you. So this is my cheat sheet of how do you interpret your cyst fluid. So first thing, we have CEA and glucose. IPMNs and MCNs, they're the opposites. So IPMN, you're going to have a high CEA. We define that as greater than 192. The glucose is the opposite. It's low, less than 50. If you look at any other type of cyst, a serous cyst, a pseudocyst, even a pancreatic neuroendocrine tumor, you're going to have a high glucose, greater than 50, and a low CEA, which we define as less than 5. What about cytology? 2/3 of the time, you're going to have a report that comes back, inadequate sample, can't see anything. What you're looking for is 2 things. Number 1, mucin on it. If you see mucin, you're probably dealing with an IPMN or an MCN. And secondly, you're looking for the presence of high-grade dysplasia or adenocarcinoma. IPMNs and MCNs are, by definition, they have dysplasia. They'll have low-grade dysplasia. Again, all we care about is high-grade dysplasia or cancer. Finally, molecular markers. How do you interpret them? So there are some places which are great. Atur Singh does a wonderful job. It comes back, if you send it to him, it'll come back and tell you exactly what it is. It's the first line of this is what it is, which is very helpful. But in case you don't get that, if you have a VHL mutation, They only occur in patients with serous cysts. So you can see here, this has 100% specificity for a serous cyst. So you've got a patient, they're really nervous in front of you, say, oh, doctor, are you sure you can't discharge me? You can say, there is very, very good data, which is 99 to 100% specificity, you have a serous cyst. We do not need to routinely follow you. Second thing, a presence of a KRAS or a GNAS mutation. You can see very good sensitivity and specificity, 85 to 97% for identifying an So a KRAS mutation can occur in an IPMN or an MCN. A GNAS exclusively occurs in an IPMN. Finally, we are getting more and more markers to help us identify the presence of high-grade dysplasia, early cancer. And if you have any of these, TP53, SMAD4, CTTN, NMB1, or mutations in the mTOR genes, they are associated with high sensitivity and specificity, 89% and 99% for the presence of high-grade dysplasia and pancreatic adenocarcinoma. Okay, so let's go back to our patient. It's, I think, did we say Wednesday morning? Was that what we said? So Wednesday morning, here you are. She's sitting in front of you. Which of these does she have? So let's work our way through it. So our radiologist, our friendly radiologist, told us she had a pseudocyst. I think we all know a lot about this. Acute and chronic pancreatitis, they can be single or multiple. The cyst fluid CEA, we said they're not IPMNs or MCNs, so you're going to have a low CEA, a high glucose. Cytology may show macrophages, and you typically don't see any mutations. I find this very helpful. So it is unbelievably rare to have a pseudocyst in the absence of a history of pancreatitis. And do you remember this lady? It was an incidental finding. So I would say that the likelihood that this is a pseudocyst is highly unlikely. Okay, serous cyst. Who's voting for a serous cyst? Anybody here in the audience? No? No? Just making sure you're all awake. Okay, serous cysts. 2/3 of these occur in women. They typically occur in their 50s, but of course they can occur at any age. They are typically single cysts. So if you have multiple cysts, it is rare that they are serous cysts. There is typically no communication or connection between the main pancreatic duct and your cyst. If you are lucky, in around 50% of cases, you're going to have this appearance here, which the cyst is made up of multiple tiny, tiny cysts called microcystic appearance, and in 15% of cases, you're going to have a central scar with calcification. Rare, but if you see it, that's really helpful. Here's your cyst fluid, low CEA, high glucose, and if you see that VHL mutation, incredibly helpful. Important point, serous cysts are benign, and they do not need routine surveillance. So if you've got a patient who's got a classic serous cyst, they've got a VHL mutation, you can stop routine surveillance. What I say to my patients is, this is wonderful. We don't have very much data on it. Sometimes they can increase in size, sometimes they stay the same, sometimes they get smaller, but you don't need routine surveillance, you don't need routine scans. If you have a problem, come back to me, and I'll consider re-imaging you, but you can discharge them from your practice. Okay, here was her EUS. If you remember, her CEA was 354. We said the cutoff was 192, so it's high. The glucose was 23. We said the cutoff was 50, so it's low. And there's no mutations. So are you guys all okay with me if I put an X through our serous cysts? Okay. So let's move on to the next one. Cancers. So cancers can present as cysts. And the reason for this is that the center of them grow rapidly, and as they do that, the center dies, it necroses, and it becomes cystic. So you can have pancreatic adenocarcinomas, pancreatic neuroendocrine tumors can present as cysts. It's not common, but it can happen. But there's typically a big solid component, as you see here. And what is the management? Here referred to a high volume pancreatic center. Why do I say a high volume center? So there's a lot of data, including a New England Journal of Medicine paper, which shows that if you refer your patient for a Whipple, in a high volume center, the risk of death is 1 to 2%. In low volume centers, the risk of death is 5 to up to 10%. So if you take one thing out of this, referring your patients to high volume centers, I think, is extremely important. Okay, no solid component. Cytology did not show cancer high-grade dysplasia. We're going to exclude that. Let's move to MCNs. Here you are. These have a very unique phenotype. They are almost all women, typically presenting in their 40s. They are always single. And 90% of the time they occur in the body or tail of the pancreas. So if you have a man, or you have multiple cysts, or you have a cyst in the head of the pancreas, you do not have an MCN. We've already spoken about the cyst fluid, which is going to be a high CEA, a low glucose. If you're lucky, you're going to have mucin, and you can have a KRAS mutation. The risk of cancer, pancreatic adenocarcinoma, is 4 to 12%. And there was a large systematic review and meta-analysis which found no cases of cancer in MCNs that were less than 3 centimeters, which had no concerning features. And based on this, new guidelines recommend that the management, that basically we tend to treat them in exactly the same way that we do an IPMN. Okay, so this was in the head of the pancreas. So we said these MCNs occur almost exclusively in the tail, so we're down to an IPMN. So first question you want to know is what type of IPMN do you have? A branch duct, a mixed, or a main duct? Main duct IPMN, that is where you have no cysts and you have an enlarged main pancreatic duct, which we define as greater than 5 millimeters. Mixed type IPMN, you have an enlarged pancreatic duct and you have cysts. Do we care whether it's a main or mixed type? No, we don't. The only reason we're interested in this is because these carry a much higher risk of your patient developing high-grade dysplasia or invasive cancer. In this modern study, they found 66% risk of this in the patients. What you do, I would say, refer on to a high-volume center to think about. Sometimes we watch these patients carefully, but you need to start thinking about that conversation. Okay, our third one, branch duct type IPMN, which is by far the commonest type of cyst that we see. It occurs equally in men and women. 40 to 50% of patients will have multiple cysts, so if you see multiple cysts in the absence of pancreatitis, you're probably dealing with branch duct type IPMN. Classically, you're going to see a connection or communication between the duct and the main pancreatic duct, and we've talked about the cyst fluid. Okay, so key point, they have malignant potential. Most will not develop pancreatic cancer, and the majority can undergo surveillance. So in 2023, how should you follow your patients? There are multiple guidelines, and I'm happy to discuss this either in the discussion or afterwards about which they are, which ones you follow and what are the differences. But I'm just going to show you what I do. So you have your patient, you look at the largest cyst. If it is less than 1 centimeter, I bring them back in 2 years. If it's 1 to 2 centimeters, I bring them back in a year. If it's big, 2 to 3 centimeters, I bring them back at 6 months. If you've got a small cyst under 2 centimeters, I follow them with MRI. If it's 2 centimeters or over, I start thinking about doing a US. If your cyst is big, 3 centimeters or larger, we start thinking about, okay, maybe do we watch or do we need to start thinking about surgery? Typically, I will follow these patients, but I think that's just the start of the time that you want to start thinking about referring them on for having that discussion. When should you start getting worried? Symptoms: jaundice or acute pancreatitis secondary to the cyst, elevated CA99. Imaging: presence of a solid component or mural nodule, which is the same thing, just smaller. Dilated pancreatic duct of 5 millimeters or greater, big cyst, 3 centimeters or greater, or cytology showing high-grade dysplasia or cancer. One level down. So if you have a patient with new onset diabetes or rapid increase in your cyst, that's a little bit worrisome. Usually it's fine, but again, I would bring them back for a short interval MRI or US, typically at 6 months. All right, our last section, challenges in the future. So this is a study from 2008, and the prevalence of pancreatic cysts was 2.6%. This is 10 years later, and the prevalence of pancreatic cysts on MRI was almost 50%. It is impossible for us to follow these. It's simply, it's not feasible. So when should we stop surveillance? It's a big question, and Dr. Vege started this, and he brought it up, and I think it's very important. So if you look at the ACG guidelines, they say when your patient is 75, you should think about, is it appropriate to continue? The radiology guidelines say stop at 80. But I would say we're just pulling a number out of the sky. And we actually need better ways of doing this. So this is one thing. If you look at this, this is the Charleston Comorbidity Index. If your patients have multiple comorbidities, 7 or more, they have an 11-fold higher chance of dying from a non-IPMN-related cause within 3 years. So patients who've got multiple comorbidities, that's probably a better way of thinking about when should we stop or should we actually be doing surveillance at all. Second question, 50% of people who are having MRIs, we're going to find cysts. We can't follow all these patients, so how do we stop? And this is a recent study published in Gastroenterology looking at almost 4,000 patients with branch duct IPMNs. And what they found was the risk of developing pancreatic malignancy in presumed branch duct IPMNs without any concerning features who've been followed for 5 years of surveillance is compatible with the general population depending on the cyst size and patient age. So patients, surveillance discontinuation could be considered after 5 years of stability in patients in firstly, those patients who were 65 years or older who had a small cyst less than 1.5 centimeters, or 2, those older than 75 with a cyst less than 3 centimeters. Because did those patients develop pancreatic cancer? They did, but their risk was the same as the general population. We're going to have new guidelines coming out next year. That's the next generation of the IAP guidelines, and they're going to say, in this cohort of patients, you can consider stopping. This was a retrospective study, although it was large, and again, I would like to see, I think we're starting to get there and get more and more data, but we are making progress. Finally, I'm putting this up to show you. I've just told you all the things that you should do for clinical imaging. Hey, when should you start referring? But I also want to highlight to you one of the challenges we have, which is they're not very good. So you can see here, cyst size 3 centimeters, as I said, start thinking about referring, but look at the sensitivity and specificity, just over 50%. Dilated pancreatic duct, this is for the presence of high-grade dysplasia or cancer. You can see sensitivity of 68%, specificity of 65%. Not very good. And I would say we need to move beyond imaging and cyst size to more precision-guided approach. This is, if you look at the guidelines, which are based almost exclusively on imaging and other features, you can see their performance here. AGA, not bad, 72, 66% sensitivity and specificity. The IAP guidelines, good sensitivity, 86%, but specificity, 36%. I would say not very good. And here you can see the molecular markers, again, for detecting high-grade dysplasia and pancreatic cancer. Better, not perfect, but I think a good step forward. One of the problems we have is this is the data that we're now getting. It's an enormous amount of data, and it's incredibly hard, and particularly as new markers come through, how do you interpret them? So I hope in the future that where AI is going to be able to help us, so you'll be sitting with your patients on Wednesday morning, and that you will have a model that will take all of this information. It will come back to you and your patients with a probability of what is the probability that your patient is a benign cyst, such as serous cyst, where you can discharge them, versus an IPMN with low-grade dysplasia who should have been monitored, versus an IPMN or an MCN with high-grade dysplasia or cancer who needs surgery. And that it will be a glass box so that you as clinicians can see what were the features that the model used to tell you that that's what it was, make sure that it makes sense, and then use this to guide therapy. And then finally, vaccines. So we have primary prevention vaccines, HPV vaccines, to prevent the development of cervical cancer. We now also have interception vaccines. That's vaccines that you can give after a genetic insult to intercept and stop development of cancer. We know some of the genes that occur early in IPMNs, then as they occur in high-grade dysplasia, and then as they occur as you develop into cancer. And there's this new trial which has started where we have a vaccine against KRAS, which is one of the earliest inciting mutations. And the concept is, could you vaccinate your patients, intercept, and stop them developing pancreatic cancer at all? So thank you so much for your time.
Thank you to all our presenters. Now we'd like to have a couple of cases presented by Dr. Varadarajulu.
Okay. So I've got 3 cases to present, and I think 2 of the patients were referred by doctors who are in this room. The first patient is an 86-year-old. She was actually a female patient with a history of pancreatic cyst that was diagnosed first in 2015. And then she had biannual surveillance with CT scan or an MRI with a different gastroenterologist. She also had an EUS done about 200 miles away from here in Florida that revealed a side branch IPMN. They measured the size to be 3 by 1.8 centimeter. So the referring doctor felt, well, there is an increase in size of the lesion, and he referred the patient to us for a surveillance by EUS based on a very recent MRI that was done. I think it was about 6 months back, and the patient is completely asymptomatic. And this is the cut and paste of the MRI report. So this MRI was done April 10, 23. Multiple non-enhancing ovoid lobulated cystic pancreatic masses measuring up to 1.6 centimeter, likely side branch IPMN, no worrisome features. These are common lesions with low malignant potential. So if I read this, the cyst and the mass don't go with each other, but anyway, not to worry. Recommended follow-up evaluation with a MRI, and then he says pancreatic mass protocol in 6 to 12 months. Additional considerations, the size becomes from 1.6 to 4.6 centimeter with central scar, septation, serous cystadenoma. And as Anne-Marie said, you really don't need to worry about it if it is really a serous cystadenoma. And then he goes on to say, attention on the above and recommend follow-up examination. So this is a very seasoned referring physician. So when he sees this report, something is not right. So he refers the patient to EUS. The patient otherwise has no past medical history. She's, just because she's 86, she's in Florida, and a lot of our elderly patients are very healthy, not a diabetic. She's got a rate-controlled AFib. Family history, the patient insisted on having this procedure is because the mom died of metastatic pancreatic cancer many years back. She walks a mile a day, requires no assistance with activities of daily living, and she's on her own. So this is the EUS that I'm going to play. So this is a Pentax linear scope that I'm using. And this is all pancreas. And you can see the cyst lesion that is making its appearance. It's got some septations to it. And I'm now going to freeze it. The only person I can target here is Anne-Marie because she does EUS and writes a chapter for our textbook. So this is what I had on EUS, Anne-Marie. Any preliminary ideas? This is just a snapshot image.
This doesn't look quite like this doesn't look classic for a serous cyst when I would look at this. So.
Yeah, this is not a pseudocyst.
Yeah, serous cyst. This
Correct.
not, yeah. This does not look like a serous cyst to me.
I mean, that is called a world-class endosonographer. So she immediately nailed it. For a lot of people, I've shown this video for a few people, and they thought, well, it could be a serous cyst. There's a small area. There's about 9 millimeters in that corner that didn't make any sense to me. So I thought I will do a biopsy on it. So this is a 22 gauge needle, and you can immediately appreciate all the abnormal single cells that are floating here. So this was actually a cancer in a cyst that's about 9 millimeters. So you got a QR code. You can answer this if you want. You should take into context what Dr. Lennon had taught us. What will be the next step in management for this patient? Would you refer this patient to a surgeon for a distal pancreatectomy? It will be an extended distal pancreatectomy. Will you send this patient to a medical oncologist for chemotherapy? Would you just, because it's a cancer in a cyst, so people say it's a slow progression. So do you want to just do a follow-up in 6 months, or you won't do anything for an 86-year-old?
I missed the histology. What's the pathology diagnosis?
Adenocarcinoma.
Adenocarcinoma.
It's an adenocarcinoma in a mucinous cyst. So I think this is not a very straightforward case. So I think I can say 50-50 on your answers, which is very fair. So I'm now going to open it to the panel and ask first with Dr. Lennon on what she would do for this patient.
Sure. So if I heard you correctly, this is an 86-year-old lady with biopsy-proven pancreatic adenocarcinoma. And on her imaging, she has no evidence of lymphadenopathy. On her imaging, she has no evidence of metastatic disease as far as we're aware. Is that correct?
Yeah, so she subsequently had a CT scan and an MRI and a PET scan. It looked like it is a local disease just confined to the pancreas.
Okay. So, what I would do is, the first question, I think even when we started is she, I know she's 86, but you can have some incredible 86-year-olds who are still running, she was walking a mile. I had somebody who jogged up 8 flights of stairs to see me 2 weeks ago and who jogs 10 miles every week. So it really, I think the first thing is let's take the age out of it and let's see what their comorbidities are. She has pancreatic adenocarcinoma. She should, if she's fit, undergo either neoadjuvant. I would check a CA19-9 if it's elevated. Typically we do neoadjuvant, and then if she is fit for it, she should have a distal pancreatectomy. That would be our approach.
Shanti?
I don't think I can improve anything other than what Anne-Marie, who is the world's expert on this, but I will just tell you as a old practicing guy, what I think, not based on science, evidence-based anything. So here is an 86-year-old lady who is reasonably functional, minimal comorbidities, cancer proven. First thing is to tell the patient that we are not going to do anything. If you want to decide about it, it's going to be challenging, not only the patient, but the family and everything. Sometimes you may win that argument. The second thing is, in an asymptomatic person, even if you detect adenocarcinoma, even if distal pancreatectomy, the surgeons can do just like that, they say it's no big deal. We have to understand, do we convert an asymptomatic patient to symptomatic thing? Because 1/3 of the patients will get diabetes if this patient is not a diabetic because the islets are in the tail. So that's a big problem for her. Besides the 25-30% immediate complication rate and 1% mortality. So the important thing is we have to consider those things. We have to have a discussion with the patient and family, and then, decide whether you're going to treat it or not. Then comes the question if you're treating, surgery, neoadjuvant, whatever, but probably surgery is one-time deal.
Can I ask you a question, Anthony, as part of that? So I agree with you. So if the patient says, I don't want anything, I totally, this is patient-centered, and the patient ultimately makes the decision. But we also, I would say each of us has inherent biases. And I think giving the patient the information so that they understand what their choices are. This is not a Whipple. It's a distal pancreatectomy. It should be typically done laparoscopically. Yes, they have a 30 to 40% risk of diabetes. But if this lady is fit and healthy with another 10 years of life ahead of her, then she has pancreatic adenocarcinoma. It will kill her, and it will, we know the life expectancy for that. She will die within the next probably 2 to 3 years. If she wishes, she can have a distal pancreatectomy. Yes, it has the mortality is going to be, there should be basically no mortality, and the morbidity is going to be what, 30%, 40% typically is what we quote. I think I understand she's older, but I would refer her, and she should at least understand what it is and then make her decision.
I think you have most experience in your center. How about, ablation endoscopically with any imaging modalities, or RFA, or electroporation, which is coming? Is there any role for that?
I don't think they're standard, and I wouldn't refer them for that, but I'll leave the rest of the team.
Yeah, I know that there is a clinical trial that the Penn State Hershey group, an R01 funded study that they are doing, but I don't think that they're treating patients with cancer. I think they're treating patients with high-grade dysplasia, because this actually would have been a very good scenario if this patient had molecular testing and you see high-grade dysplasia. In this particular patient, should you send the patient for surgery, you do not have proven cancer, but you have dysplasia. So, but I don't think if there is cancer, I agree that surgical resection, a discussion about that would be the next step.
So very, Shyam, maybe isolated case reports are coming of electroporation, RFA, both for metastatic lesions in the pancreas and also small adenocarcinomas when they are 86, atrial fibrillation, etc. Do you have any experience?
We do admit that we do RFA, but if you ask me where is the evidence, Anne-Marie would know, we have zero evidence to show in adenocarcinoma whether it's helpful. It's 12 millimeters. I offered the patient surgery. You have to know that this is not Hopkins, this is not Mayo Clinic. This is community setting. There are not many good surgeons who will be willing to operate on an 86-year-old patient. So generally, I tend to send them away to one of my favorite surgeons, actually in Birmingham, if there's a complex case, who do these surgeries. So this patient wanted to have surgery. She was very clear. Hey, listen, I'm on my own. I can live through it. Just send me wherever I need to go. So it's a misconception that people come to retire in Florida. They come to retire to live forever. So this is actually this is a very good paper in the Red Journal. Actually, Dr. Wilcox had written an editorial on it, and it's very easy to miss the big picture. When you look at a pancreatic cyst, they categorize into low-risk patient, high-risk cyst, low-risk patient, low-risk cyst, high-risk patient, low-risk cyst, and then a high-risk patient with a high-risk cyst. And this patient fell somewhere here. It's a low-risk patient because she's got really not much comorbidity. It's a high-risk cyst. Close surveillance is what they recommend, but to be honest, because she is in a fairly good functional status. I referred her for a distal pancreatectomy. This happened hardly a month back. I don't know what happened to the outcome of this patient, but stratifying them by comorbidity is very important, and I think we need to go from there. Otherwise, in a very busy clinical practice, we just tend to survey them. Survey them for what? So, and the reason that you should not completely neglect when they say, well, it's a cyst is there all of the time, let it go. We can't keep following these patients. All of the above is true, but this data is very simple. If you've got a cyst, and if you have got a cancer in that setting, and if you operate on a very high-risk cyst, if you have a very high-risk cyst and there is no cancer, and if you intervene early, 5-year survival is 100% when done by expert surgeons. Minute cancer sets in, survival decreases by almost 40 to 50%. It takes a very different route. That is the reason it is important to be very thoughtful with pancreatic cyst management. It's just you have to read the guidelines, order the correct testing, follow them conscientiously, put them in a database, and do it in a very methodical way, because there's a huge difference in outcomes once it becomes malignant. So early diagnosis and correct diagnosis, despite all the limitations, is key to correct management of patients. And as I've told you earlier, we have an AI program that we are working on very, very early to identify early stage cancer, but that's my interest. We'll probably cut down on the break by 10 minutes so that I can present every case. So the second patient is a 61-year-old. As a female patient, again referred, I think, by the same doctor for evaluation of acute recurrent pancreatitis. Patient reported 7 episodes of pancreatitis starting in January 21. Each episode is associated with 2 to 3 days of hospitalization. She's asymptomatic in between these episodes. Absolutely no problem. Doesn't know any triggering factors. There's no smoking, there's no drinking, there's no alcohol use, no family history of pancreatic cancer. And this is the imaging with which she came. It's a pretty decent imaging. I wouldn't say it's a pristine MRCP, but it's a pretty good imaging. Now let's take a poll. So you've got a patient with recurrent pancreatitis. Imaging is okay. It doesn't look like the cancer or anything. What will you do for this patient? Will you refer this patient to an EUS? Will you just tell the patient to be on a low-fat diet? Will you refer the patient for an ERCP with pancreatic sphincterotomy and stenting, because by definition this is type 2 SOD, pancreatic SOD? Or will you just manage this patient conservatively and with lifestyle changes? So that's a very good one. Refer the patient for a cholecystectomy. I think you're right. I think you probably figured out that's what I would do. So I did an EUS on this patient. And then that is the aorta that you see. So most of you may not be familiar. And as you retract the scope, you'll always find the pancreas. You can see when you look at this pancreas, it's a very beautiful pancreas, which means this patient is not smoking, not drinking. You got the ventral analaga, which is actually usually very prominent, and then you got a normal dorsal, and then you gradually pull, and then I don't see the bile duct. You just see the pancreatic duct going into a different place in the duodenum. So EUS is not very accurate for pancreas divisum, but if you do a lot of it, you can pick up divisum. So I thought this patient may have pancreas divisum. And I did do an ERCP for this patient, and we will discuss whether this is the correct treatment approach in a short time. So this is the single-use scope, which is what I use, and you have to go on the semi-long scope position. This is called a 543 cannula, which is Rob's favorite cannula for cannulating the minor. The wire is called a Nova Gold. It's a 018 guide wire. And then once you go into the pancreas, it just flies inside, and then you do a pancreatogram to confirm the diagnosis of pancreas divisum. And then the traditional treatment is to leave a 3 or a 4 French pancreatic stent. And then before that, you can do a pancreatic sphincterotomy. So that's a pancreatic stent. And then I did a sphincterotomy over the stent. And what you're trying to do is to unroof the sphincter. The clinical update is that the patient did not have, since March of this year, I have not seen this patient. I presume no pancreatitis. I just want to stop here and ask our panel. Pancreas divisum, recurrent pancreatitis, too much data have come from you, contrary to what I am doing. Just give me your words of wisdom.
I will
Yeah.
ask you one additional thing to answer along with Shyam. So suppose if this patient got a genetic testing and CFTR is positive, and similar patient you have without CFTR, would you be treating these two patients differently? Of course, the treatment is minor papillary sphincterotomy.
Yeah, and both of those are very important, relevant questions for which I don't think we have answers at this time. So, Shyam mentioned about a clinical trial called SHARP, which is sphincterotomy for acute recurrent pancreatitis. This is an ongoing multi-center international trial that is trying to answer this question, whether doing a minor papillary sphincterotomy in patients who have recurrent pancreatitis, idiopathic recurrent pancreatitis and divisum would improve their clinical course. There is only one randomized trial in this area that was published in 1992 with 19 patients. And the literature is mostly related to or published on observational retrospective data. One of the things that you just mentioned, that you have not seen this patient since March, what the data are lacking is how long do you have to follow these patients to really understand the natural course, whether this patient is going to have recurrent attacks over a long period of time or not. And this trial is trying to answer this question. The second question that Dr. Vege mentioned in terms of CFTR mutations, so in pancreas divisum, the hypothesis is that because the minor papilla is small, the drainage of the whole pancreas is through a smaller opening, which increases pressure, and we know that ductal obstruction to the pancreas increases risk for pancreatitis. In patients who have CFTR mutations, there is decrease in secretion. So the point is that these patients probably are at a higher risk for pancreatitis. And do patients who have divisum and CFTR mutations have higher risk for pancreatitis? This was actually seen in observational studies published from France, and other studies like Andres Gerlud and others have shown that CFTR mutations are more prevalent in patients who have divisum and recurrent pancreatitis. But a well-designed randomized clinical trial is probably the best way to answer the question.
Dheeraj, you had a question from the audience, which would be, if they had a gallbladder, would you send them for a cholecystectomy?
Yeah, so that was actually a great question. I would have wanted to ask, did this patient had liver test abnormalities or not during the attacks of pancreatitis? Often in patients who have idiopathic recurrent acute pancreatitis, so if patient has abnormal LFTs during attacks of pancreatitis, that's a strong indicator that the patient likely has underlying sludge or stones that are passing through. But even in the absence of that, and Dr. Vege has actually published that in a population study from Mayo, that if you have a patient who has recurrent pancreatitis with no gallstones on imaging and normal LFTs, these patients may not benefit as well from cholecystectomy. No, I completely agree. So the point that I'm trying to make here is I agree with you that a patient with recurrent acute pancreatitis, in these patients, a discussion about empiric cholecystectomy is a very valid discussion. And we offer this to our patients who have recurrent pancreatitis with a good discussion that there is a possibility that they may not benefit from the procedure. But that's, common things are common.
So this is your last case, and we will just take some your word of wisdom from Dr. Vege, and then we will end this session. This is a 48-year-old male who comes with abdominal pain for 3 years, weight loss of about 30 pounds. Pain is unremitting. Pain is all the time. The minimum pain is 6 out of 10. It impairs activities of daily living, is unable to hold a job. Pain episode is associated with nausea, but there is no vomiting. Can't sleep, and there are no aggravating factors. Patient was referred for an EUS. Patient is a type 2 diabetic. There's hypertension. Patient is on metformin and some antihypertensive medications, takes tramadol 50 milligram every 4 hours. The patient quit drinking 2 years back and was a heavy drinker, smokes half a pack of cigarettes to this day. The CT scan report is a dilated, irregular main pancreatic duct with stones and a cyst of 2.5 centimeter in the neck of the pancreas. And this is the EUS examination of this pancreas. So once again, you start your EUS in the second portion of the duodenum, and then you pull back. And immediately, right away, you see a cyst right at the in the Unsnet process. And then you see a lot of bright spots. We call them hyperechoic foci. You See, the duct is dilated a little bit here, and there is an intervening stricture in association with a stone. You got everything, a stone, cyst, dilated duct, a stricture, and all the classic features by EUS of what you will call pancreatic cancer. And the reason you do EUS is you don't want to miss a solid mass. And then the duct is now dilated downstream all the way from the neck to the tail of the pancreas. So in addition to recommending smoking cessation, what is the next step in management? Will you do a block? These are your 4 options that you can choose from. Will you place a stent? Because you got a nice ductal dilation in the tail. All the disease is confined to the neck and the uncinate region. Maybe we can get a wire and stent this patient. Low-fat diet, continue with tramadol and all those things Dr. Vege said, vitamins, antioxidants. Maybe consider creon for this patient and titrate it with the diet. Or will you tell the patient who's losing weight, no dietary restrictions, but you should do everything that is on question 3 and add a tricyclic to it and get a nutritional assessment. This is important because as an endoscopist, whatever I write on my report and then I tell the patient, I refer them to medical pancreatology to Dr. Wilcox, he trashes them because he practices evidence-based medical pancreatology. He tells me, listen, all those nonsense that you write don't work. So I want you to choose from these 4 options and then we will have Shanti give some words of wisdom.
So one thing for sure I'll do, based on what I have said in my talk, that even though you can add TCA, probably I will go for pregabalin. That's number 1, because it's easy, Lyrica. And then the question is ERCP and pancreatic duct stent placement. Celiac plexus block, I won't do it. So 1 is out. And this cyst is pseudocyst or side by side?
Yeah, it's a pseudocyst.
It looks like pseudocyst.
Yeah, it's a pseudocyst.
So I think at this point of time, I probably would try to do endoscopic therapy with Lyrica.
Okay.
And Lyrica is one thing which is a new thing in my thing. But I will give a benefit of doubt for the endoscopic treatment for this lady to have pain relief. I know it has some complications. It's a continuous pain. But doing both, I'm trying to see, because she's 48, and assuming she's going to stop this thing. At this point of time, I won't subject her to surgery.
Okay.
So I have a question. Is the patient still drinking?
The patient has stopped drinking for 2 years.
Okay.